You can always talk to me offline at the break. I'm not hiding. The next thing that I'd like to do is introduce my friend, colleague, and fellow board member, Leslie Saint-Jacques. With 12 years of combined experience as a physician assistant in perioperative neurosurgery and cardiovascular surgery ICU, Leslie has been immersed in intense clinical environments, and these environments have been increasingly pressurized by the pandemic. Leslie's career has been characterized by intensity from the start. She was a brand new PA grad from the first class of McMaster's PA program. Leslie and her classmates worked through uncertainty and adversity to break down barriers and help establish the new clinical role in Ontario. She later worked as the first PA co-lead and PA education lead at the University Health Network. She became president of CAPA's board of directors and is currently serving as past president. Leslie is very interested in how compassion and the interpersonal environments we are steeped in set the tone for our experiences as PAs, PA students, patients, and family members. In addition to her PA life, Leslie's not sitting around. She is a psychotherapist with a master's in social work. As a research assistant on faculty projects and in her thesis research, Leslie's gained experience with qualitative research methods. She completed a graduate diploma in clinical epidemiology at McMaster University, and if that's not enough, she's just begun a PhD in health professions education research at the University of Toronto. Leslie loves the great outdoors and hiking trails, comedy, and beautiful food, and best of all, when these things are combined. She's very excited to visit La Belle Provence, and she's looking forward to speaking to you today about compassion under pressure. Veuillez nous joindre pour souhaiter la bienvenue à notre amie et collègue Leslie Saint-Jacques.
Good morning, everyone. It's really great to see so many of you here. Oh, thank you. I was a little bit worried about doing the morning session. If people were going to be having such a great time, finally getting to see friends again after so long, that you had your priorities straight and we're out partying last night and sleeping in today. But I'm really glad to see so many people here, and I want to thank Kevin actually for his leadership as our president. I've had the pleasure of working closely with three of our presidents, Chris Rule, and then Eric Damaris, and now Kevin, and also Kirsten, our future president. And it's been a really great opportunity for me, and I've learned a lot. I also want to say this is our very first hybrid program, so that gives a lot of extra stress to our staff and to our technical assistant as well. And I really want to say thank you to Christy and Sandra and Patrick for bringing this all together, and a round of applause for them, if you don't mind. So my talk this morning is about compassion. And you might be wondering, why is there a house on fire as my first slide? So there's two reasons why I was thinking about fire. First of all, it does feel like our healthcare system is on fire. It's a little bit dampened down now, but it's still fairly problematic. And we've all walked through that fire in the last few years in the situations where we're working clinically, but also perhaps as a family member. And I know that we've also lost a lot of loved ones. So we have been walking through the fire, we still are. And so that is a very appropriate image, I think. Secondly, though, compassion is also related to burnout. And as you'll see in the talk, the fact that we have a real deep inner fire for our clinical work leaves us quite vulnerable to burnout. And so that's another thing I'm going to talk about coming up. I don't have any financial disclosures. I don't have any financial incentives to be here, but I am a PhD student, and this compassion is my topic of interest. And something that I hope to learn a lot more about. And so I'm pretty invested in it as a topic, but I'm also invested in compassion because I'm a PA. And I don't want to work in a healthcare system where I'm being squished so hard that I don't feel like I have it in me anymore. And so I think we all in this room have a vested interest in compassion. So what we're going to talk about is meanings of compassion, things that make it really difficult to help people with compassion, things that make it difficult for us to be receivers of compassion, and also the things that are protective and helpful, and some strategies and some organizations that are working on this. So I just want to ask to begin with, at the outset of this talk, what's your idea of compassion? What do you think of when you think about it? Is there a time that you've really witnessed a deep connection between a healthcare provider and a receiver? Is there a time when you really felt that you had a nice deep connection with the people that you were helping? This is a definition that tends to circulate in medical literature. Different fields have slightly different versions of this. In medical literature, they tend to contrast empathy with compassion. So they're slightly different. Empathy being an emotional experience that is the same. So I can feel what you're feeling. I get in tune with you when I'm listening. But compassion takes it a step further and say, well, what are you going to do about it? So I can feel what you're feeling and say, oh, that's really horrible. I feel that's horrible. But compassion is that little extra bit of, now how can I help? And taking action to do it. Whether it's just, getting somebody an extra blanket, or advocating for them where they need some help getting through the system, or when they phone you for the 10th time about an outpatient issue, you're still kind to them, you still listen, and you help them sort it out. So the taking action is a really important part there. So the last almost 10 years, 8+ years, I've worked at the University Health Network, which is affiliated with the University of Toronto. And I've been working in neurosurgery there. I loved it a lot. And it also brought me in touch with a lot of PAs. My previous job, I worked in Hamilton. There was only 2 of us at the time, which you probably know Vincent Lacherte. He was my coworker and wonderful, but the 2 of us were pretty isolated compared to coming to University Health Network, where there was already a handful when I started. Now we're at least 50, I would say. And that feels so good to be around people who understand what PAs are. They're support network for each other. Even better, or even more helpful for all 50 of us, is that our leadership at the University Health Network really understands PAs, and they're very behind us. And when I was thinking about going to do a PhD, I came across this book, which happens to be written by the person who is the higher person above the PA portfolio at University Health Network. And I didn't know he had written this book. And then when I started reading it, I was really convinced, like, yeah, this is exactly what I want to focus on. So a lot of the talk that I've presenting you today comes from this book, which is it's edited by 3 people, all involved with University Health Network and University of Toronto. And the authors also are very involved with medical education and education in other fields as well, interprofessional education. And this book is quite interesting. So Brian Hodges is our, I just want to mention this because this is important for all of us as well, all of you. Brian Hodges is the new president-elect of the Royal College of Physicians and Surgeons. So that just makes me so happy that someone who knows PAs, who knows a lot of PAs, is stepping into that position. So in terms of compassion in this context of this book in particular, and some others I'm going to share with you, I was wondering, what are people going to think? Are they going to think that we're going to talk about yoga, mindfulness, walks in the woods, like I was a little bit worried about letting Kevin down. I know he wanted to hear about that this morning, but we can talk about that later because I do like all those things. But in this book in particular, they focus on the context of our work as physician assistants, as occupational therapists, physiotherapists, you know, all of the different professions that are working in healthcare, and the social structures, the systemic issues. There's talk about discrimination, equity, diversity. Talk about what is it like to be involved as a patient advocate or an engaged partner in the healthcare system. So this book does not blame us. It's not saying you need more yoga, you need more sleep, you need more pizza lunches. This book is about what context are we operating in? And I really want to get into some of those issues because whatever is going on, and I am also a social worker and psychotherapist in addition to PA. So I often say to people, you know, what's happening to you is not your fault. And I felt like, yeah, actually, I'm saying that too in this talk. Like, what's happening to us is not really our fault. What's happening to us is a much bigger picture. So getting down to a little bit deeper here, compassion to me means, am I present with the person that I'm talking to? Am I hearing you? Like, am I seeing you? And I've definitely had some situations where that I really felt that was happening, and it feels so nice. And as a social work student, and also as a PA student a while back, in both situations, I remember feeling like, I have to learn this, I have to learn that, I've got to get my checklist in order. Like, I'm going to ask them about the differential diagnosis, I'm going to ask them medications, and you're going through the list of everything you have to ask. But I think the important thing that we sometimes forget, and I hope that we can teach our students and also to embody in the work that we do, is that the main thing that people need when they come to us doesn't have to do necessarily with the checklists. Like, being clinically excellent is so important because we are protectors, we're the helpers, we're the person who is going to fix this person's medical problems, which is essential and very important to be clinically excellent. But if you're not able to pay attention, you're not even going to get that medical information. If I'm doing my emails while the person is talking to me on online conversation, obviously I'm not there, I'm not really present, whether they're in the room with me or they're online. If you're not really present, you're missing information, but you're also missing the emotional side of things. So this quote comes from psychoanalysis way back, but still very true, I think, to our purpose sometimes, is learn your theories as well as you can, but put them aside when you touch the miracle of the living soul. So compassion for me has to do with how we show up for one another as human beings. It also relates to many different concepts like caring, respect, equity, and recognizing another person's humanity. So Brian Hodges, in the introduction of the book that I was talking about, Without Compassion, There Is No Health Care, has written that for some time, compassion has lost prominence as the governing tenet of healthcare work. Compassionate care is vulnerable when stacked against the constant imperative to be efficient, the distancing gaze of science, and the rapid, expansive logic of automation. When compassion is diminished, healthcare becomes ineffective or even harmful to those who receive treatment, as well as for those who provide it. So now I want to ask you, as you're looking at this slide, what do these terms mean to you? Moral distress and burnout. Moral distress actually is a term I didn't know until COVID, and I was helping look up some resources for healthcare workers to kind of help build a resource, an online resource for healthcare workers to access. And so we were looking at also the psychological side and the stress that we're all under and how to manage it. And that's when I learned about moral distress. It made so much sense. It made so much sense to some of the things that I've seen and the pain that I have over some situations that you just feel like, you know, that's the feeling, like, what can I do? I'm in a situation, what can I do? And I wanted to mention, I just want to tell a little story about something that happened to me as a PA student. And I was in the surgery environment. I've always thought about surgery as a career. And I was doing an elective placement. And I remember a patient who had cancer coming into the OR. And they were waiting there. And we're, of course, going through the chart, like, what do we need to know? Their meds, anything? What's the history here? And as a student, I was very new, like this might have been one of my early OR experiences. And so I'm following the staff physician, like, what am I supposed to be doing? And he's getting prepped, and everybody in the room is doing everything they can to prep for this patient. And I became aware that the patient was crying over on their bed, waiting for us. And they were sort of saying in general to everyone, I'm scared. I'm really scared. And I feel like, am I going to die? Like, what's going to happen to me? I didn't get a chance to call my family. Like, and that was like so awful. And it happened, 2009. And it's still with me as if it was yesterday, because if I could, now knowing what I know and the experience that I have, I definitely would go over and hold that person's hand and say, we're going to get you through this. But that person was crying by themselves in a room full of people. They were alone emotionally in a room full of people who were all doing everything they could to get this person safely through the surgery. But nobody was able to go over or really recognize the need that that patient had at the time. So I would say that was a pretty good example of a situation of moral distress. And of course, over the years, I've had a lot of them, and I'm sure you all have as well, where we think back and say, like, man, I would do that differently next time. And then burnout. We're going to talk a little bit more about burnout. So moral distress occurs when one feels unable to take what they believe to be an ethically appropriate or right course of action, including avoiding wrongdoing or harm, because of institutionalized obstacles. It's a psychological response to an experience of moral conflict or moral constraint, which is especially likely to occur during public health emergencies and in other situations when there are extreme resource limitations affecting patient care and the safety of healthcare workers. And this definition is from the Canadian Medical Association, a pamphlet on moral distress in COVID-19. Notice that they also are talking about institutionalized obstacles. They also agree with me and with many other authors, and especially those in the book Without Compassion, that what's happening to us is not a moral failing of us. It has to do with a much bigger context. So burnout is specifically work-related, as opposed to exhaustion or alienation from your job, where you like maybe bored with your job, you just don't want to do it anymore. It's like so tedious. It's not something that you had a passion for anyway. And now you could go on to something else. You probably have a recovery. Burnout, not that it's not possible to recover, but burnout is specifically work-related. A gradual process of disillusionment in the quest to derive a sense of existential significance from work. So existential meaning about existence, about the meaning of existence, about why am I here? Why am I here as a PA? Why am I here? Why am I here doing this work in healthcare? Why am I here working, afraid to go home in case somebody drops the ball, or afraid to go home in case I forgot something, because I don't want to go home and remember, oh yeah, I forgot that. So, we all have a sense of a passion toward our work. And I think it's pretty likely that most PAs do, that we didn't get into this for the lucrative pay. We probably got into this related to passion for helping people, passion for medicine, passion for the type of help that we can provide, and maybe wanting to be that person who does play a very significant role in other people's lives. Burnout is a state of fatigue and emotional exhaustion related to disillusionment. When highly motivated professionals who identify with their work and hope to derive from it a sense of existential significance fail to accomplish their work goals and feel unable to make a significant contribution, they become susceptible to burnout. So who among us has not felt this during COVID, when we're pressured to take on a lot more patients, a lot more work, we're not able to get the work done? In some cases, me working in neurosurgery, we had ORs canceled. So, we literally could not do the work that was needed. And eventually they opened it up so that we were allowed to do emergent cases where life and death situations, that's it. So it was a pretty significant decrease, because in some cases our neurosurgery cases are not exactly life and death today, and those people got put off. So sometimes that's even cancer. So another major issue that I want to talk about is the context that we work in has, of course, systemic issues. We live in a society that's imperfect. We live in a society where there is racism, there's discrimination on multiple grounds that still exists. And in some cases, there's a backlash going on. Sometimes the imperfect society, of course, people who live in the imperfect society includes us. We are also of the imperfect society. And we need to think about, how is discrimination affecting the care that we can provide? How is it affecting our patients? And for many of my colleagues, they're facing discrimination because of their own marginalized, racialized backgrounds, where patients have been quite rude to them as well. So sometimes we have discrimination inflicted on us. That makes a difference in how we feel about the work that we're doing and our connections with others. So this too has an organizational component, that our organizations need to foster a health promoting work environment where employees feel respected at work, where we, no matter what our background is or how different we may be from the people that we're working for, from our supervisors, that we are also treated with respect, that people who are from marginalized, racialized backgrounds, that they have extra support so that they're not having to deal with a vulnerable situation by themselves. And that racism is addressed, and people can talk about issues like this without fear of reprisal. So one of the stories that really touched me in the book by Hodges is a story from Jennifer Johansson, who was an engaged patient advocate, family member. She had a child who was born with multiple disabilities, and he passed away when he was 12. But in the meantime, she had to navigate a really difficult system. And before she became a bioethicist, she noticed that there are certain things that she needed to do to keep favor with the people who are caregivers. And notably, this quote from her says how stressful and tiring it was, trying to ensure that we were always seen to be deserving of good care. And this actually reverberated with some things that I've heard and read from other places as well. And in fact, said to my own family, like, you know, I'm taking you to emerge, have a shower and put on your best clothes, because that's what you need to do to get the care that you need. I think it's a statement for sure about first impressions, judgments, but also, as you know, sometimes people's behavior is annoying. Sometimes they get on the wrong side of ourselves or colleagues, and they don't always get the care that they deserve. So equity must precede compassion. Strangely, you know, I've been writing a lot of grant proposals lately as a PhD student, and hoping to be successful in this. It's not so easy to find in the literature. Where does equity come into the definition of compassion? Of course, in the book that I am so in love with, yes, there is a chapter or two in there about that, and there are some authors who are writing about how you cannot have compassion if you are discriminating against someone, because if we're talking about I see you, I hear you, I respect you and what you need. If there's a problematic discriminatory structure, which of course there is, but if we're not recognizing that, we're not recognizing the differences between each other, and in some cases that means they need something else that we don't know about, and so it's okay to ask, like, what else do you need? How else can I help? Because my experience is different than yours, but I care and I want to provide what you need. Representation amongst our staff is also a very important issue. Representation means that the people that work in the organization reflect the population that they're serving. So Martimianakis et al. in this Without Compassion, they talk about how a healthcare workforce that is representative is also shows who is valued as a healthcare worker, who have we hired, and why are we caring about not only who works here, but who we're serving, and making sure that we have the right people. So challenges to compassion. It's a very long list. I'm just going to summarize this slide here. Really, I want to highlight this efficiency mandate is very problematic. It squishes us down into more patients, more work than anyone can possibly do within the hours that we're usually given to do it in. We have to get more people through the OR faster. That means we have to discharge people faster. Efficiency is not always in favor of good patient care. The racism that we talked about, bullying of staff towards our learners, bullying of staff to staff, social isolation at work, which could be you're being excluded, you're not like us, you don't represent the same values as us, maybe people think, or you're not an insider. That can be quite a painful place to be, as well as isolation that we've faced from COVID. And then there's another factor there, which is a lot of us felt, as I felt, I had a daughter who was pregnant at the time during COVID, felt like, I don't want to take this home. Before we knew what it was, before we knew how to protect ourselves or our families, we're all washing our groceries. Like we didn't know what we were taking home. And so I've spent the last few years being quite isolated from even my own family, because I was worried about that. And then personal issues come into this a little bit. I know I said it's not our fault, but there are some things that maybe we do that are harmful to ourselves. For example, overusing alcohol sometimes, or not getting exercise, working too much, not sleeping enough. And then, of course, anyone who's interested in academia or thinks they might make a transition that way, there's the pressure to publish. Maybe you already feel that as part of your job if you have a research component. So this is just another way of talking about how we are being squished so much that our tendency to be altruistic is used against us, where we're working a lot of overtime. We are not taking breaks. We're not taking lunches. We're not hanging out with our friends. We're skipping things that are important to look after ourselves because there's too much work to do. There's just not enough work to do. And in fact, a terrible habit of my own, which I would really like to stop being this way, is I would rather go home on time than have lunch, which is not, it's not ideal, because then you don't get to know your colleagues as well. You don't get to support your colleagues as well. And also you don't get the support from them, which is not helpful. Because we all like to laugh. And something that we've had I'm so happy for with this conference is just being able to chat with people and laugh has been like such a welcome thing. So healthcare professionals can't be compassionate if the organizations that they work for are not compassionate for them. And make no mistake that caring work is emotionally, mentally, and physically effortful. You don't always have it in you to listen intently. Sometimes we do have the roommate in the back of our heads that is telling us like, next you have to do this, next you have to do that, you need to do this person needs to be here at that time, make the call. Like we're not always so good at being grounded and mindful and paying attention. It's work. And here I just want to say that in the literature, there is really good support for us that as healthcare workers, it is recognized that this culture of efficiency is making it very difficult for us to do the work that we want to do in the way that we want to do it. And that's where the thing about burnout comes in, because when I feel like I'm not being effective or I can't be effective, or I say like, well, that's just the way it is. We just have to deal with that. And then that moral distress of like perhaps discharging a homeless neurosurgery patient, knowing that they're going straight back to the street. These things are very difficult, and I think they do add up to burnout. So as a PA, I just want to talk about how do we find out what our role is? What is your role on your team as a PA? And what is expected of you? And how do you even know what's expected of you? Becoming a PA has a lot to do with taking on a professional identity, figuring out what you're supposed to be doing as a PA. Like when I was in the OR in that story I told you, I'm figuring out what am I supposed to be doing here? Am I supposed to be helping in this way or that way? What's important? What are the values? In a large hospital system where there's always way too many people in emerge who are facing life-threatening things, they need to get upstairs really quickly. Very clear that our mandate is that help that person get better and get on to the next appropriate setting as fast as possible, so that we can help the next person who's also in crisis in the ER. So these kind of messages, I'm sure they're not in the CAF program, in the McMaster program, which I did, in the U of T program, and your programs in the US. These situations aren't necessarily talked about. We learn them when we get into our work as PAs. We learn them in the settings in which we're in. Maybe what's expected of you when you're in emerge is different than what's expected of you in general surgery, or is expected of you as a PA deployed. So you find out from the people around you, from watching them, what you're supposed to be doing there. And that's called the hidden curriculum. So our official curriculum that the programs are teaching us is very important, and values. There's a lot of values that we're taught, which are important values, and which we leave school agreeing with. We want to keep those values. We believe in them. And then when we get into the settings, even in clerkship, you're in a setting where, as I was in that OR, you realize like, oh, there's other stuff that I'm finding out now what's expected of me. So we learn what really matters and what it means to be good at your job and what your manager wants and what your healthcare system wants from being in it, in the soup that we exist in. So the values-based teaching tends to unravel in the day-to-day reality. The misalignment of the teaching that we do in the PA programs doesn't always fit with the reality in the workplace. And this dissonance for healthcare providers is something that education programs have started to think about. How are we going to help our learners to anticipate and prepare and have a sense that sometimes stuff's going to happen that that you might not agree with? How are you going to handle it? So I want to come back to the idea of do we have time to be compassionate? And in some cases, we think we don't, but we might, because that extra gesture, like being real with somebody doesn't actually take extra time. It's more perhaps of being like present. And that doesn't really take more time. In fact, it saves us time, because if my mind is only on one thing, I can deal with that one thing in a focused way and then move on to the next thing. So being able to look someone in the eye when you're talking to them, to be paying attention to what they're feeling, what they need from you, and to be able to respond appropriately. These things don't really take a lot more time. And in fact, there's been studies of, you probably know this study of when physicians sit down in the room with a patient, the patient feels like that person's spending lots of time there. But actually, in the study, they didn't actually spend any extra time there at all. They were there the same amount of time, but it just seemed like this is where I am. I'm not like half out the door, which is, you know, sometimes that's how I have been. Like I'm half out the door. Like, I'll see you. I just want to make sure you're still okay, and I got to run. And that's not. It's not giving the person the actual attention and the feeling, which is true, that I do care what happens to you. So these high demand, low control environments are said to be very, very high risk for burnout. In some cases, they talk about how nurses have a very high risk of burnout because they're not the boss. They're not the one who makes the decisions. Ultimately, they're not in control. And when stuff's happening that they don't agree with, which is common, very, very common, and experienced nurses will say to me like, what's happening here? You know, this is not the way. And it's very stressful for them. And so I think as a PA, I'm not the boss. Stuff, you know, I don't really have a lot of control over what I have a lot of advocacy. I can do a lot, and I know all of you can as well. You can do a lot by knowing how to navigate the system that you're in, but ultimately there are things that we can't control. And this feeling sometimes that stuff's happening that we wish we could do something about what we can't is quite painful. Well, who here hasn't had a problem with a colleague? Anyone want to raise your hand? We all have, right? It's common. It's so common and so painful. And you don't want to get into conflict with your colleagues. Most of us don't like conflict, but it happens and misunderstandings happen. And those things are extremely difficult to navigate. The people that we work with, on the other hand, and how I really ripped myself off by not taking lunches, those people that we work with are also our biggest source of support. So in COVID, there was extra supports for healthcare professionals to help us to manage stress. There's lots of stuff out there that was particularly oriented for healthcare professionals, but a lot of people didn't use it. And that's because they didn't really need to. because maybe they have a colleague who's a good listener. And that person gets it, like they get it. They're in the same system, they're in the same situation, they know. And so a lot of people will turn to a trusted friend and get lots of support that way. Your family, of course, is a very big source of support too. So being able to have family or friends or colleagues that you hang out with outside of work, very, very important as a way to help us feel human ourselves, to laugh about stuff, to be able to commiserate about stuff, and to let off steam. And then, of course, there are some factors, and this is not to say in any way, I think I've been pretty open about my position on this. What's happening in the system is not about us necessarily, but I'm looking at a whole lot of military people here. You know, when you're going into a situation that you're going to have to be strong, that you have to be ready for that. And part of it is how you look after yourself, your nutrition, your sleep, your rest, and also mentally, your mental focus. One factor also, which many of us, military or not, unfortunately have dealt with in life, is a trauma history. So anyone who's had a history of significant trauma, apparently in the literature, is more vulnerable to burnout. So some of the reasons why, like if you were to say, why do we care about compassion? There's efficiency issues. So it's good for the system, actually. If we're compassionate, we help people to the best that we can with what they need right away. They don't bounce back. It's good for the relationships among staff. We get sued less. Better health outcomes, compassionate doctors are giving better care, and probably, I'm sure, compassionate PAs as well. And also there are mandates in some places that we should provide compassionate care in our legislation and codes of ethics. So compassion toward healthcare workers is also an organizational responsibility. And as we've all seen through COVID, this is government as well. Government has a role in what's happening in our healthcare system, much more obviously during COVID than what we've seen before. So in what ways are these structures and organizations supporting us, making sure that we have the salary support or the relationship support that we need? Compassionate organizations have compassionate leaders. They appreciate the challenges and the tensions that we're going through. And the leadership, for example, the leadership that I talked about at my previous workplace, they truly get it. They put a lot of things in place for us. It's not enough, of course. There's still a lot of burnout. There's still a lot of people leaving, and even with what the leadership can do, there's still more to be done. One of the main things which I highlighted on this slide is the need to eliminate unrealistic work expectations. Well, who's in charge of that? Our managers, our supervisors, but also me, right? I have unrealistic expectations of how things are going to go and what I need to get done, before I go home. Compassionate leaders, of course, are also aware of the systemic issues in our society, the power that they have, the power that we have over patients, the power that managers and supervisors have over us. And if there are situations that are happening which are discriminatory, that the leadership needs to deal with that. The focus, which is in the literature and I completely want to promote here, is that it's important to think about burnout as much as it is to think about reducing wait times. They're not really separate issues. So some things that support compassionate care, of course, are interpersonal, our collaboration with each other, teamwork, our own sense of agency, like what control do I have over my own day and how I manage my relationships with patients and others, social responsibility and positive relationships at work. So how do we create the environments within healthcare systems that allow us to engage with our patients and our coworkers as people, as human beings who are together in a joint endeavor to help this person, a human being in front of us, get the care that they need? And in some ways, it's allowing for not just medically, clinically excellent care, but also the recognition that some patients are facing extremely hard things. For example, cancer, or someone is dying of something else, and family members need our compassion as well. There's the emotion that we deal with needs some time. Of course, seeing each other as human beings is a challenge to this unidirectional gaze that I know what you need and I'm looking at you and you should be listening to me. Obviously, if you think about that person as a human being who knows what they need, and going back to Jennifer Johansson and her child, who is she knows what that child needs. So being able to ask and collaborate with her about what those needs are. How many people have had a situation where they have a patient who's, for example, on a medication, who knows what will happen if they stop taking their medication? For example, like Parkinson's medications. When you're going into a surgery with a Parkinson's history, you already know, like, there's going to be periods after the surgery where my body needs I need certain things. And if your healthcare providers are like, yeah, whatever, it's like insulin. No, it is not, right? Like, and the patient knows that, the patient knows how to manage their disease, especially a very serious chronic one like that. They know what they need, and we should really be taking cues from them. So our relationships with each other are super, super important, as well as taking care of ourselves, which I mentioned earlier. And I'm not totally throwing away the idea of mindfulness and yoga. I'm a believer. And I think we could talk a bit about deep breathing in through your nose, out through your mouth. Box breathing, everybody knows. Anyways, those things are helpful. And I know I've gotten into the habit of when I'm in a stressful situation, doing those things which are a little bit more social worky to deal with the conflict situation, for example, of grounding myself, like feeling my feet rooted in the ground, taking a deep breath, making sure that I am breathing deeply to calm myself and the other people. These kind of strategies are useful to help us survive in these environments where we're being so squished. So these 4 organizations, I put their websites up there, are really focused on compassion and the interrelationships that we have with our patients. Tons of great supports there. And this AMS Healthcare is from Ontario. They're based in Toronto, and they have put out, actually, I think they might even have a grant proposal available now for anyone interested, related to how do we keep our healthcare system compassionate even while things are becoming so technological. There's so much technology available. Where can we make sure that we are still human to human, even when all these other technological advances are helping us to get the job done? And I put a few references there because our slides are going to be up online later, so they may be too small to read now, but if you want to see them later. So thank you, everybody, for listening. And is there anything that you would like to share, or questions, anything you'd like to ask? Yeah. Yes. Oh, yeah. Oh, yeah. And I think as PAs, you know, we often are the person, the continuous person through the system when residents are coming and going. And so we do have a better idea when the patient's asking us, like, what happens to me next? What do I do next? Where do I get these labs? Where do I find out? And, you know, we are the person who sometimes explains these things. We're often also, sadly, the person who is having serious illness conversations. We're the person who is giving sometimes the diagnosis and explaining what it means. So, yeah, our role for sure is really super important in explaining what this means to you and your family as a patient, and what you can do to help yourself. Your aftercare instructions, for example. I don't know if others in different fields have the same experience as me, but it's usually me who tells you what you need to worry about, when to come back to emerge, that kind of stuff. Yes. About who's taking you home tonight, what are you having for dinner? What are you going to do tomorrow? Plan on making watching a movie, have a grocery breakfast, and like that stuff as well. They don't have any decisions going forward because for weekend plan in addition to those things. And so like having the work away and like you do, I want that to happen and make that sense. It's reassuring, like sending them off that maybe still be okay. Right. And they probably also have your phone number, right? Like they know who to, oh, they don't? Oh. I don't mean your home phone number. I don't mean you're giving them your cell, but no, I meant like they know who to call if they have a problem, or they know what to do if they have a problem. They'll be texting you. Any other comments or stories anyone wants to talk about, or yes? Sort of build on these comments that I feel like our classification here better. And I don't know how many times I didn't do the first provider to tell someone you have that this is the first time they hear. And so we've got documentation of different professionals that yes, we reviewed the diabetes, you know, guidelines, you should be under 7%, this and that. They don't have any recollection. Yeah. So I made that connection. It's really important for their success. Definitely. Definitely. Okay. Thank you. Thank you, everyone.